Hey Doc, so the first thing we're going to talk about is hemorrhagic shock, and then one of my favorite drugs, TXA.
Awesome.
I absolutely love this.
So we're starting out, MedOps is going to be carrying blood products, 2 units of packed red blood cells, 2 units of plasma. Patients probably will only be getting one of these at a time, but we want for multiple patients, as well as if somebody is really in shock. Depending on the success of this, we may or may not expand it out to other units. We'd ideally like to have them strategically located around the county, so that way we can timely respond to accidents and people that need it. Basically, administration of blood products is going to be limited to those that undergo a 4-hour training module. It does require special post-licensure skills with the state, so we have to have you approved to administer it. So if you're not approved and don't have the PLS, you can't give it. But one of the exciting things is that all units will now be carrying TXA.
Absolutely fantastic drug. TXA has been around forever. I know the OB has used it forever to save many, many women's lives. But
Right.
Where I came about with it is during the Afghan War, 82nd Airborne showed what a life-saving drug. And the one time that I used it, other than an OB call, it stabilized the actual femoral that was nicked with a bullet so well that interventional radiology didn't even touch it. They're like, it's stabilized.
Nice.
Fantastic drug.
Yeah,
and we'll show you how to mix that here in a few.
It's been used in cardiac surgery as well. They use it very routinely for patients like that.
Ah, I didn't know that. Oh, for like AV valve replacements and stuff.
Right.
Ah.
All the bleeding that occurs with that. So this is from the ATLS textbook, and of course I don't expect you to memorize this, but basically we're looking at patients getting blood products and TXA when they're in class 3 shock, kind of toward 2 going towards 3. Problem with that is class 3 shock is associated sometimes with about 50% mortality if it's not treated aggressively and quickly, which is why TXA in the field is something that's very beneficial for patients because it stops the bleeding, which is the #1 cause for doing that. If you think class 1 is somebody that donates a unit of blood, you really have minimal symptoms with that and you can tolerate that pretty easily. Class 2 is when you're starting to get some physiologic changes. And then class 3 is where you're getting the drop in the blood pressure, you're getting elevated heart rates, you're starting to get anxious. And then class 4 is when you have altered mental status. And class 4 is really associated with very high mortality, approaching 65% with that.
Hey Doc, so we don't want to have our guys look just on the BP and say, okay, they've been right at 110, oh, now they're 90, now they need to be jumping on. We should be looking at that trend, correct?
Right.
And see, hey, they're 120, 110. That shows you they're decreasing. We need to be more aggressive and on top of that sooner, do we not?
So there's 2 things that you can look for. One is the first thing you're going to see is the heart rate going up.
Yes,
so
sir.
if the heart rate's above 110, that's an indication for TXA or an indication for blood products. The other thing is a shock index, which is basically the heart rate over the blood pressure, and if that's greater than 1, then basically if the heart rate is above the systolic blood pressure, that's an indication for TXA, for somebody that has a traumatic injury or some sort of hemorrhagic shock.
And I'm glad you said the shock index because our Zoll monitors does the shock index for you. So it's just a tiny little number, and I can go back and re-show you guys that on the monitor, but it'll show you the shock index. So that would be also something that you can look at to help you out, make a decision, a clinical decision.
Awesome. So what does TXA do? I'll spare you the clotting cascade of trying to learn that, and I'm not even sure I even remember it because it's been over 20 years since I was in medical school. But basically, TXA is an anti-fibrinolytic drug, so it prevents clot breakdown by preventing fibrin and clots from breaking down or fibrinolysis. It's really used extensively in the ORs, as David mentioned. It's in OB/GYN, cardiac surgery uses it, and we use it a lot in the ER too for patients in shock.
Awesome.
So why do we use it? There's a couple of studies. The CRASH-2 study, the clinical randomization of antifibrinolytic and significant hemorrhage 2, which is a lot of words that you say, so basically CRASH-2 is a lot easier. It looked at 20,000 patients. It was in over 250 hospitals in 40 different countries. They got 2 grams of TXA, and this is a little different than how we've transitioned over the years to administering it. And basically for every 67 patients that got TXA, it prevented 1 death. The military application or MATTERS trial was actually a lot better, and probably you had experience with this in that if you gave TXA to 7 patients, one would have a prevented death. So 1 in 7 is the number needed to treat. And since then, there's actually been some better data that's came out from that. So how does TXA impact treatment? It's kind of like the defibrillation curve that you look at for cardiac arrest patients, and that if you give it immediately, it's a 70% improvement in survival, and then each 15-minute delay decreases your chance of survival by 10%. If you remember ventricular fibrillation, it decreases 10% per minute.
Correct.
This is 10% every 15 minutes, but it's a similar philosophy.
And I know we've made our protocol, we've tried to make it very simple. We were talking about those clinical decisions a minute ago, that if you're on the fence, but some of it's very simple. Patient's shot multiple times, we've got a lot of blood loss, you're putting tourniquets on, it's a no-brainer.
Right, right.
So,
and just keep in mind that if it's after 3 hours, there's really no benefit to administering this.
that's correct.
So when do we do it? If it's a traumatic injury, or if they have active bleeding, if it's a GI bleed, if it's some sort of vaginal bleeding post-delivery, if their systolic is less than 90, their heart rate is greater than 110, or if they have that shock index. If they're 15 and up, then they would get TXA and blood products if MedOps is available. 14 and below does require an online order for MedOps or for blood products, just by its state restrictions from that.
Oh, gotcha.
When we,
but would it be on the TXA, we can still give them less than 14?
Correct.
If they met it. Okay.
The blood products, when we moved that through the EMS MDAC committee, basically Dr. Linzer from CHOA had mentioned some things that there really wasn't any data from the pilot project that they did with blood products in the field in Northeast Georgia.
Okay.
So that's the reason why it's not a standing order for kids to receive blood products.
Gotcha. But they'll go back to look at that later, because I know the Hall study, it was actually out there in Hall County, and I know they just didn't have a big pediatric population that they could have gave it to.
Right.
We're Metro Atlanta, so we'll have a higher population. So you think they'll go back to that eventually?
Probably so. It'll probably be a couple of years before we revisit that.
Gotcha.
So the studies initially did 1 gram bolus, and then they gave 1 gram over 8 hours. Newer research really supports 2 gram bolus, and it's a lot easier to administer than trying to calculate an infusion. So our protocol is going to be 2 gram bolus, and we're going to use it again for hemorrhagic shock if the systolic blood pressure is less than 90 or the heart rate's greater than 110. The other thing I'll say is this concept of permissive hypotension. If you flood somebody with IV fluids, it doesn't replace the blood products. All it does is thin the blood, it thins all the clotting factors, it makes the bleeding worse. Yep. So if you don't have blood products, you really should try to aim to keep the blood pressure in the 80 to 90 range. Obviously, when they're in the 60s or 70s, there's perfusion problems with that, so you probably should give them fluids. But if somebody's blood pressure is 85, you should ride with it and let it be, because the mortality data is a lot better if you don't aggressively fluid resuscitate these patients.
And I know some of the studies from the 82nd Airborne, they had people with bilateral amputations, shot multiple times, and these people were only getting maybe 100 cc's of crystalloid and actually flying all the way to Germany.
Yeah.
So it just shows you that we should be cautious about giving a lot of fluid. And then when we do give the fluid, let's say their blood pressure is in 70, try it out with maybe 50 to 100 cc's, see what we bring that blood pressure up, and just keep them there.
Right. And a lot of this data is based on studies from Ken Maddox in Houston that date all the way back to the 1980s. And it's still a concept that, the first thing we think is we got to get the blood pressure up, fluid bolus, fluid bolus, fluid bolus, because we didn't have blood products in the field. And it actually causes harm when you do that.
Well, remember when we started out, it was 3 liters until the breath sounds are wet.
Oh, yeah. So, I remember the mass trouser days, too.
There you go.
All right. I saved this for last, but this should be the first thing. And I saved this for last because I really wanted to emphasize the importance of this. And the primary treatment for hemorrhagic shock is to stop the bleeding.
Correct. Tourniquets, tourniquets, tourniquets.
Right. Tourniquets. Look at scalp wounds. I mean, they bleed, an exorbitant amount with that. The chest and abdomen, you're really not going to be able to do very much with. Long bones, splinting, speed splints or traction splints. The pelvis, we have pelvic binders, the SAM splint that we can put on patients, and then retroperitoneal, you can't really do very much with, but it's something to keep in consideration.
And wound packing.
Wound packing.
Wound packing is underutilized. I know some of our people actually had a motorcycle wreck where they ended up having to splint one, only did one tourniquet on it, splinted the other one, and then they wound packed. And I was like, congratulations. I mean, stop the hemorrhage. Always stop it.
Right. And then one final thought is keep the patient warm, because cold induces coagulopathy, so patients bleed more when they're cold. If you'll notice in the trauma bay, the first thing that patients get there, we expose them and then we cover them up like 3 or 4 heated blankets, because the colder they get, the more they bleed.
And that actually goes back to the military calling it the trimodial death.
Right.
And part of that is the coldness. So remember, we all have the warming blankets. Every piece of equipment in this county has the little blankets, and they have the actual mummy suit that they can put them in. So TXA, Doc, we're going to push it out to all ALS units. We already went over it again. You guys got the protocols. It's going to be on hand heavy. There's going to be 2 ways you guys can give this. So your TXA is going to come 1 gram in your vial. And we're giving 2 grams, correct, sir?
Correct.
So something that's going to happen is we used to all have these 100 cc bags. We understand we're not going to be carrying stuff now where we're going to be doing IV pumps. Also, there's been some issues with some of the fluid actually evaporating over time. So what we've done is we've gone to a no little 100 bag. So you guys have 2 options. I like the KISS principle. We can either do 2 grams, put in your 100 bag, start on an IV line, and just go to town.
Mm-hmm.
And then that way, if you're doing permissive hypotension, you can get a secondary line, start looking at the permissive hypotension. Or you can draw up the straight 2 grams and do the bolus slowly over 10 minutes. So 2 choices, dealer's choice at the time. Just remember that if you're going to use that same line after the TXA, we need to flush it out real good, correct?
Right.
So,
particularly if you're giving blood products.
especially giving blood products.